How often would you say PAs change specialties during their career? How common is it? I would say it's very common, and I don't know how often they do, but I think a lot of PAs, once they find a specialty they like, they do. But I've met a PA that I think has done 4 specialties so far. Hi everyone. Hello, welcome to e-shadowing. I'm so sorry for the delay. I've been having internet issues, troubles all day, and I was trying to log into my desktop, but it's not working, so I had to rush and get my laptop, and it just took forever to connect to the internet, but we're here. Happy Monday. So I'll be hosting today. Thankfully, he let me know early enough for me to put together a presentation for you guys. So it's going to be, the typical flow of me doing an ER segment and answering your ER questions. I know that, sometimes we have issues with guests. We're going to have an actual guest next week. She's an aesthetic PA. So we'll get to see how it is with like cosmetic procedures and more voluntary type of surgical procedures, or we'll see if she does surgical or if she just kind of does injections. But yeah, I'm excited to have her next week. But today, of course, I'll be doing the emergency medicine. And like I always say, the good thing about ER is that there's so much to know and learn. You see so many different things. So even though we might not have a cardiology PA, we'll do some cardiology or pulmonology or pulmonary, I should say, or nephrology, urology. You'll just see always a little bit of each specialty within the emergency medicine setting. So we'll jump right in. Of course, it's just so weird to be on my laptop, like at home, like in the office, because I'm never on my laptop in this office. I'm usually on my desktop. But so I'll start off by, of course, answering your PA questions. I have to. I actually did not want to cancel e-shadowing today. I was just been running late all day. I was home for the weekend, back in South Florida for the weekend for my brother's wedding, if you guys follow me on Instagram. And then I had to come back to town today because I have to leave for Pensacola. Well, I had to come back to town last night because I have to leave for Pensacola today. And the way they do it, my travel agency, like I have to pick up a rental, go to a hotel. So I had to pick up a rental from here in Georgia. And I didn't want to cancel e-shadowing. So I chose to get on the road later today rather than earlier, because I don't want like the times to conflict and me not making in time for e-shadowing. So I really, really have to end at like 8 o'clock so I can get on the road as soon as possible, because it's a 4.5 hour drive to Pensacola. So I'm sorry if it's going to be cut a little short. So we're only going to be doing like 15 minutes of questions, guys, and then the PowerPoint, so we can try to finish by 8 o'clock on time. Yeah, I know I canceled last week and I felt so bad, so I didn't want to cancel this week though. All right, guys. So yeah, let's get into emergency medicine. Yeah, any questions about, not just emergency medicine, of course, everything PA, of course. Yes, I'll provide the MedSimbly link to you guys. Let me just send it to you guys. Thank you so much, everyone, for your well wishes. Yes, I'm going to get there safely. Let me, somebody asked for the MedSimbly link. I'll send it to you guys. MedSimbly is my platform that I created, an app where pre-PA and PA students, or PA just healthcare students and pre-health students, can connect with and find mentors and coaches in their areas to help them with their PA journey. You can find in-person shadowing, general mentorship, just it's really to build intimate relationships and personal relationships with those that already made it, so they can help guide you through. Because y'all, advisors don't really know much, especially like general college advisors. They won't know much to help you through the process. And especially for those that are like first generation college students, or just, non-traditional students, really need that guidance, really need that help getting to where you're going. That's what MedSimbly is for. You can message these people directly. They'll message you back. They're actually PAs that want to help you. Okay, so you don't have to kind of go looking for people on LinkedIn or Facebook groups or whatever it is. So you know that the objective is to help you. All right, so how did you deal with, okay, I'm trying to see the questions as they come in. All right, first let me send the link to you guys, and then I see some questions coming in. just airdrop the link because I use so many devices. It's usually on my phone. So here's the link. I don't know how to pin it. I don't think we can do that. So I just sent the link to you guys. So first question I see besides that was, do you think the field PAs, NPs will be saturated? How much need do you see for PAs soon, or do you still see a gap, I'm guessing? Actually, no, I don't think it will ever be saturated. Just like healthcare, just our doctors won't ever be saturated. If anything, the need is only going to grow. Maybe certain specialties in certain areas may be saturated with PAs, but the general need of PAs, NPs, or healthcare providers as a whole will never be, because people are only getting older. Technology or medical technology advancements are only going to continue. So people are living longer. There's going to be more people on this earth. There's going to be more need for healthcare, especially for the elderly population, more need for providers, I should say. And less people are going or choosing the MD or DO route and going towards a quicker route like PA and NP. So the need is only going to grow. There's actually a worldwide healthcare worker shortage. Like how many did I read? I think like over 20 countries are facing a shortage. So hopefully, like, PAs will be more known in other countries. There are countries like Canada. I mean, Canada's a continent, right? No, wait, Canada's not a continent. Canada's part of North America. I am not dumb. I was so good at geography back in the day, but yeah, countries like Canada accept PAs. I'm not sure, and then Europe, but yeah, hopefully it will be more known globally, so PAs can work and fill that gap in other countries, especially third world countries. But yeah, I don't think that it will be heavily saturated. Like I said, maybe some specialties, but not all. Which specialty has the highest demand for PAs? Good question. I actually don't know. I would say maybe family medicine, because that's where, family, internal medicine, hospitalists, ER is always in need. Yeah, I don't really know the exact specialty or the number one specialty, though. Thank you, guys. I had an interview a few weeks ago that I thought went really well, but I ended up getting waitlisted. Do you have any advice on how to objectively look back on interviews to better prepare for the next few? Let's see. Well, other than, a lot of the schools will not respond if you ask them, oh, where did I go wrong, or what can you say? I would say to reflect on how the interview went. If you can remember, a lot of times, like, you kind of black out and be like, you interview and then you don't remember anything that happened, anything you said. Sometimes that happens to me, especially if you're super nervous. So I would say, if you can, reflect on how the interview went from the moment you walked in. Well, I'm sure it wasn't in person. The moment you logged into your desktop or computer, laptop, and logged into Zoom, whatever software they use, to the moment you logged out. Try to recollect how everything went. Try to think about what you wore, how you looked, how you sat, how you presented yourself, the way you answered the questions, your facial expressions, if you can recall. It's really about recollecting and thinking about, each step, where could I have gone wrong? I mean, you're not going to say where could I have gone wrong, but replaying that, and objectively, you can involve someone else, discuss it with someone else, and then they can tell you, I think you might have gone wrong this way, because you thought you did great, like you said, you don't know. And it could have been could have not been you. It could have just been that they had so many students, and waitlist is not a rejection, right? So they have a lot of students. They probably matched up your interview, even though your interview didn't go as you thought it would. When they compared you to another student, it could have been that, the breaking point was, they interviewed really well, but this student's, essay was better or GPA was better. I don't know how they end up waitlisting people or go about it, but that could have been the case. It probably wasn't completely your interview, but just so many students and it being so competitive. But of course, try to the best you can to go back on how you did on the interview, recollect it, talk to others about it, talk to people that had interviews, and if you can, people that went to that school. I think that's the best way to find out about a school, and how they interview, their interview process, how they go about selecting students, if the current students know, but talk to current students that got in the program. They'll give you the greatest advice as they know and they got in. So I would do that as well. And then you can do a mock interview as well, with the current student, and try to interview the same way you did. I would do a run through of interviewing the same way you did, and they'll let you know. And then of course, you can build from that, and they'll let you know where you went wrong, what to do, and you can practice the new interview technique. So yes. Would you say that PAs have a solid relationship with their doctors? Are they well trusted among patients? Are the PAs well trusted among patients? I think PAs are well trusted among patients, unless a patient really is ignorant to the PA profession and what PAs do, and then that's up to you to explain that. But solid relationship with their doctors, I would say, depends on the specialty. Some specialties you don't see your attending, honestly, or supervising physician, I would say, like urgent care, if you work in a sole provider practice or with other providers and they really just have a doctor there to sign off on charts, but he's not physically there, you'll never meet your attending. Or some practices like psychiatry. I think the practice where you probably work the closest with your attending is like surgery, maybe hospital medicine, maybe family medicine. But a lot of practices, they kind of just have that doctor there just because they need a physician to sign off and to be a medical director, but you don't actually see them. So there's not like that relationship, but you have their contact information. Like the urgent care I work at, I'll have the contact information for that doctor I'm working with for the day, and I just like text him, hey, hi, I'm such and such, and I'm working with, or I'm working today, and you'll be signing off on my charts. That's what it is sometimes. And that just kind of means you're practicing pretty independently, right? So the relationship is not there for some specialties, and others it is. Like the ER, there's so many doctors that can work within a week or day or whatever, a month. So you might not meet all of them unless you work full time and always there. And some doctors are per diem, some doctors are locums like me, some doctors are part time. So it really varies. Is it hard to get into emergency medicine straight out of PA school? Yes, I would say it is. But then again, it also depends on where you live. Some places are more open to new grads versus others. Like I found that the East Coast is really open, like New York. My friend got a job in Virginia out of PA school. I think she lived in Virginia, and she got paid pretty well. But I'm sure the cost of living there could be crazy. But yes, it really depends where you live. The South is not so much. The South, you definitely need some experience, at least a year of experience before they hire you. But the like New York, I saw a lot of them. Like when I worked at the hospital in New York, a lot of them said they got jobs out of PA school. Like they did a rotation there, and they got a job offer. They were able to get a job and get trained on the job. So yes, it can be very difficult. Why do you think it's so hard for new grads to find work? Because of the level of training, because you're new. That's the keyword, new grad. So it's going to take a lot to train you for, and a lot of people, a lot of providers, or a lot of facilities, hospitals, private practices, they don't really have the time, especially if it's like a super busy clinic or a hospital. They don't always have the time to train new grads, because the most important thing when you get out of school is that training. You getting to become comfortable with what you're doing. You're gonna have crazy imposter syndrome. You're gonna not think that you know anything, even though you do. It's gonna take time for you to get your nerves up or get your nerves out the way and learn to talk to patients, learn some bedside manners. Not in bed. I don't mean bedside manners, just like kind of being polite, but just learning like the flow of patient care. And so it takes time to do all that. So I would say that that's why. And it's going to take at least 6 months for you to get really, really comfortable. No matter what specialty, I think it just takes 6 months. Then you have to learn the EMR system. You have to learn whatever technology they use. Some of these EMR systems are very antiquated and just terrible. Meditech. So yeah, it's a lot to learn, not just the patient care, but everything that goes on behind the scenes, like charting. So yeah, it's a lot to learn to hire a new grad. I find that surgical specialties are very open to new grads, and then doing new grad residency programs are great. So if you want to get into a specific specialty and you don't as a new grad, that's fine. Get in where you fit in. That's what I say. I always say, get in where you fit in. Get in, get your foot in the door, just get used to talking to patients, get used to evaluating patients, get used to ordering stuff. No matter what specialty you do, you're going to order lives, you're going to diagnose patients, you're going to work with the attending physician. So get used to just doing general stuff if you're not able to get in your specialty. So get used to doing general stuff before you actually get in there. So it could be a blessing in disguise. So I think it was great that I didn't get into the ER right off the bat. Because it's crazy. So I just kind of first got used to, how medicine and healthcare works, and then, the specialty. So it's fine if you don't. So just first get your first year of experience as a PA in general, and then even if it's family medicine, primary care, just, get your foot wet, get your foot in the door. What happens if the doctor doesn't sign off on your chart? Oh, they will. The hospital will come after them. The facility will come after them. The office manager will come out after them. If the doctor has a problem with your chart, like they want you to fix something, and when you start off, the doctors will probably read over your charts more, like more thoroughly. A lot of them will just sign, and they won't read over. And I want a doctor, when I first start off somewhere, I want the doctor to look over it to make sure, I don't care how much experience I have, I wanted to make sure that it's to their liking in case something happens, until they kind of feel more comfortable with me, whether it's, they have to read 5 charts before they kind of say, oh, I'm comfortable. Okay, your charts look good, whatever. Because, everybody has their own little preferences. So, yeah, I would say make sure your attending is okay with your charts. And I say attending and supervising physician for those that don't know. I use them interchangeably. So, yeah, make sure your attending is fine with that. So that's the reason why they wouldn't sign off on charts if they're not okay with something that you wrote, or they just get behind because they have their own charts to sign off on along with other PAs. The only thing that happens is they get in trouble. So they will sign off on them because they need them for billing purposes. Shadowing hours. Oh, somebody said shadowing hours are exempt for the upcoming year. I'm not sure how long this will last, but I am going to tell you guys, even if a school says they do not require shadowing, I strongly, strongly recommend you shadow a provider, especially if you don't have that much patient care hours. Shadow a PA. I strongly, strongly, strongly recommend it because that's going to help you with your essay. The point of your essay is going to be why PA. You won't know why PA if you've never worked with a PA, if you've never seen how PA is, if you've never seen how the profession is, how PAs order stuff, how PAs talk to their physician, supervising physician, how it actually is. So shadowing helps with all of that. So even doing this, like a virtual shadowing, you're learning about the PA career. You're getting more knowledge on the PA career, and that's the point. So you can effectively, state that in your essay, right? So even if schools exempt that, still do it. As you work in emergency medicine, do you have to ever deal with psych patients as much as doctors do? Oh, yeah. Of course. Every ER is different. Some ERs have it designated where certain patients are seen by the doctor. Some ERs don't. Some ERs just kind of put, like, unless they're like level 1 cardiac arrest, the doctor sees those. But, or level 2 near death. But every other patient, the PA can see. So there's, but like I said, it depends on the facility, but most of the facilities I've worked at, we see psych as well. How to get the experience if they don't offer you a job? If they don't offer you a job, you just apply. You connect with recruiters. I can't wait to tell you guys all about recruiters because I didn't learn this when I graduated PA school, and it's so important, especially if you want to work in the ER. these agencies or these hospitals, they hire recruitment firms and staffing agencies to fill their ERs or hospitals as a whole, whether it's hospital medicine, emergency medicine, whatever you do in the hospital system. A lot of times they use recruiters. So it's so important for you to connect with these recruiters, because they'll send you emails, they send you text messages about needs, about positions that they're having, whether it's locums, which means temporary, or permanent positions. And there's a bunch of staffing agencies or recruitment firms. So schools don't tell you this, but get in with recruiters. How often would you say PAs change specialties during their career? How common is it? I would say it's very common, and I don't know how often they do, but I think a lot of PAs, once they find a specialty they do. But I've met a PA that I think has done 4 specialties so far. But you can do it as much as you want. You can do whatever you want. So yeah, there's nothing wrong with changing specialties. So you can do 2 specialties. Like I said, I've met PAs that do OB and then do ER, do a part-time thing, do surgery and do ER, you can do whatever you want. There's so much flexibility. How many types of bloods are there? I don't know what that means. Like blood types, like AB, ABO, ABO, A positive, B negative. I don't know. I mean, they're all just different combinations. So I can't, off the top of my head, say how many types, but you don't have to know those, like the exact types or how many types there are. You have to know that there's blood types and when to order blood typing. But with the rise in PAs, does it look like the PA fellowship will become a requirement? Maybe not officially required by the PA program, but by employers? No, I wouldn't say that. I don't think PA fellowships will become a requirement. A lot of jobs want people are ready for you to kind of just get out there and start working. Although it does take time to train PAs. The thing is, it doesn't take that much time. It doesn't take really more than 3 to 6 months for a PA to really adapt and get used to their specialty or their job. So I don't think a fellowship will be a thing for every specialty. For new grads who are interested in emergency medicine, would you advise working in urgent care settings to get experience before moving? Actually, I don't advise that, because a lot of these urgent cares move so fast, and there's no supervising physician. When you start off, the best thing to do is to cling on to your supervising physician or a seasoned PA in that practice or that hospital, right? If you want to get into emergency medicine, work in emergency medicine first. If you want to work in emergency medicine, if you do urgent care, make sure there's a lot of support there. Make sure that you're going to be working with a doctor. Make sure it's not a crazy urgent care where it gets super busy, where you can make mistakes, because the busier it gets, when you see 50 patients a day, there's a lot more room for error. So you don't want that. I would not advise, really. I mean, unless once you get to work and you pick up quick, but I would say try to work somewhere that's not so crazy busy, especially the first 3 to 6 months. If you go in when it's not season, when it's not this time of the year, great. If you go in during the summer, it might be better. But try to get somewhere where it's not so busy, so you can adequately learn and have an attending there to help you. So that's what I say. And urgent care, a lot of times, is very independent. You practice very independently. A lot of times it could just be you on your own, stuck. So but in the ER, there's a lot of support. There's a lot of more providers working there at a time. There's a lot more physicians available. There's a lot more PAs and NPs that can help you too. So that's why I recommend doing ER. I mean, doing another going to the ER more primarily before urgent care. So yes. What piqued your interest and made you choose emergency medicine to practice? Because it was awesome. I saw so many different things. That was the main thing that pushed me to emergency medicine. I saw so much in a day. Like I said, you see so many different specialties. It's not just one thing. You're not going to just see OB stuff all day or cardio all day, or urology, gynecology, whatever all day. You see all of that. You have the opportunity to see every single specialty in one day, in one shift. Within 12 hours, you can see everything, literally. And that's what I liked about ER. It never gets bored. You never stop learning. So yeah. And you learn everything. What are some, sorry, it's like this stuff is brief. Okay, I'm trying to make sure I answered everything. No. What are some challenges or threats that face the PA profession aside from patients unfamiliar with it? I would say like autonomy, us not having as much autonomy or the same privileges as NPs, and of course, I would say, you know, a lot of places are more NP friendly versus PA friendly. People knowing more about the profession, not just patients, but just people in healthcare knowing more about the profession, accepting the profession, and of course, autonomy, being able to open our own practice, being able to do, I mean, you can open your own practice, but like with the doctor, but I think NPs can just open it on their own. But I think it's fine to open your own practice with a, you know, a physician to sign off on your charts. But yeah, those are some of the things, those challenges. Why are there anesthesia PAs when there are CRNAs and A's dominating the field? I've never heard of an anesthesia PA. I've never heard of that's I don't that's the only specialty PAs don't do. I've actually never heard of that. It's really CRNAs and AAs. If you're still trying to find a PA to shadow, just please, I actually created a Google form for students to let me know the areas that they need PAs to shadow. Or you can also DM me, tell me I need a PA to shadow, and I'll work on getting those PAs on MedSembly, or PAs from those areas on MedSembly. Once again, I'll put the link if you join. And then we can send an announcement like there's new PAs from different areas and specialties. So like email notifications or announcements. What did you mean by recruiters? How did you get in contact with them? I will do a whole segment. I think talking about recruiters is so premature for you guys since you guys are not in PA school yet. It's basically like recruitment, like getting you in a job or helping you get a job or literally recruiting you for a position. So I can do a whole segment, maybe a Facebook live, IG live on recruiters and stuff in healthcare, especially for PA students that are going to graduate soon because it's so important. Especially if you want to get into ER, hospital medicine. Yes, recruiters are so important. I mean, even certain specialties, or even if you want to travel in the future. What is your advice with students who have a low GPA? A low GPA, it's okay to have a low GPA. That's not the worst thing in the world. Just put your energy into other things. Of course, if you have a low GPA, work on getting your science GPA up, which means retaking some of your classes, your core classes, your science classes. Make sure you minimize your C's. Retake your classes is the best way to show that, oh shoot, it's 740. Okay, I'm sorry, but that's the last question. I am so sorry, guys. It's 740. Sorry, I'm just reading the stuff. If you have questions for me, then you can either join MedSembly and message me on there, or email me, Instagram me. Let me put it, because I have to. I'm sorry, guys. I'll answer this last question and get to the PowerPoint. If I don't answer your question, just DM me. Low GPA, yes. Put your energy, first of course, as I said, work on your science GPAs, minimize your C's. I would say don't have more than 1 C, or if you can, 2. Try to avoid 3 C's in your science classes. That's one thing. And then try to fix your GPAs by retaking classes. And if you can, or it barely changes, then of course put your energy into other things. Like, don't be a dead horse. If the GPA is dead, it ain't going nowhere, ain't no reviving it. move on to the next, okay? Put your strengths, put your talents somewhere else, right? So if your talent is going to be in volunteer work, if your talent is going to be creating something amazing, if your talent is going to be founding something at your school or founding a pre-PA club at your school, leadership roles, put your talent into that and highlight all that. Highlight your strengths that you bring. Don't talk so much about your weaknesses, grades, whatever. That's not everything. Highlight all your strengths. Put energy into, volunteering, doing great things in the community, doing something amazing. Or what's the other thing? Patient care hours. Collect a bunch of patient care hours. Collect more than, not collect, acquire like 2,000 hours. Work your butt off to have as many hours as you can. Get ample experience in healthcare, not just patient care, but shadowing, volunteering at clinics, volunteering at COVID stuff. Do a lot of get really involved into healthcare. But basically, just put your energy into other things that can make your application great. Okay, GPA is not everything. I hope that helped you guys. I'm sorry, but I have to do this PowerPoint now. All right, today, yes, it's very lit. Okay, PowerPoint. All right, so emergency medicine segment. Today it's all about, well, first, everybody knows this. I'm sure all of you guys are used to me by now, about my words first, about my pearls, about what's important in the ER. You guys are going to be ready to be emergency medicine PAs by the time you start PA school, right? So let's get started. All right, a 42-year-old male presents with complaint of right flank pain / back pain times 2 days. So what does flank mean? Does anybody know what flank means? If you know what it means, put it in the chat for everyone else. Look at his vitals. So first thing first, of course, so the patient's going to come up on the tracker in the ER. The tracker is going to be the EMR system tracker. So say you use Epic, you're going to be logged in and it's going to show all the patients and then it's going to show patients that's waiting to be seen. So you have this patient that's waiting to be seen. You pick the patient up. You open the patient's chart and you see this, you see the complication, you see the patient's vitals. Yeah, the flank is like your side where your kidneys are. All right, so the vitals, are they looking normal? Are they looking good or no? Yeah, good job, guys. So yes, flank is like your side. Fatima, great. Blood pressure is high. What else? Tacky, great, Sydney. Quinn, yes, all of you are great. So this patient is tachycardic and has a high blood pressure. Why does the 42-year-old male blood pressure so high and he's tachycardic? So do you guys know why? Can you guys tell me why in this instance that could be the case? Does he have high blood pressure or does he have hypertension? Or could he have hypertension? Think about that. We'll move on. All right, what are some questions you'd want to know? I'm not answering these. I'm letting you guys answer these. Kidney function could be bad. Yeah, kidneys could be a cause of hypertension. Kidney issues could be a cause. Good job. All right, but what are some questions you'd want to know? You're about to interview this man. You're about to take a history and physical, right? When did the pain start? Good. Rate level of pain. History of stones. Awesome, Brittany. Yes. BP, pain can rise. Perfect, Christelle. Perfect. Yes. When a patient's in pain, their blood pressure and heart rate can cause, yes. Pain can cause high BP and heart rate. Yes. When you're in pain, when you're under stress, remember high blood pressure, not necessarily hypertension, but high blood pressure. All right. So you're going to do your, because this is related to pain, right? OPPQRSTA. This is what it stands for. So this is going to help guide your history. All right. So you're going to ask about onset. When did this start? Provocation is like what's making it worse. Palliation is what making it better. So have they taken any medications to make it better? Has anything made it worse, like moving around? The quality is is it sharp, dull? The patients never know that though. Like they never know, can say, oh, my pain is sharp, my pain is dull, my pain is this and that. They just kind of say, oh, it hurts. And then radiation, does it go? A lot of times pain in your flanks can radiate to your belly, right? It can go radiate to your abdomen. Severity of the pain, scale 1 to 10, how bad is the pain? Timing of the pain, does it come on at a specific time? Do you notice it after eating, or do you notice it while, straining to have a bowel movement? Whatever, timing. associated symptoms. And then with time, you can also ask, palliation, you can ask, oh, does it help it go away, or does it go away spontaneously? How long it lasts? And associated symptoms is part of your ROS. So do you have any fever with this? Do you have any nausea, vomiting, diarrhea? Do you have a headache with this? Like what kind of symptoms come along with this pain? So you're gonna do all these, your OPPQRSTA, and then a lot of times this will already be there, you guys. As I said, if they're like not a new patient, or the nurse will ask them their past medical history, surgical history, family history, social history. So the nurse will ask them this, or if you don't see it, you can of course ask them. Or if they're not a new patient, it'll be in their chart, or you can get updated information. But yeah, so you'll ask their OPPQRSTA, and then you'll ask them about their past medical, surgical. So let's say this guy had a pain the past 2 days. The pain's at first it was coming and going. Now it's been constant. It's just not going away. It's a sharp pain. It goes kind of to his side. The timing, it just nonstop. Associated symptoms is nausea, no vomiting, no fever, no diarrhea. And remember, when you ask the associated symptoms, you kind of have to be focused, right? If he's having flank pain, you don't really have to ask him if he has a headache with it, right? You with flank, you're going to ask more stuff that's associated with the flank area or the kidneys or abdominal area, because you're asking like, related body systems, right? So you asked about urinary symptoms. That's important to ask. Associated symptoms, any burning when you pee, any peeing a lot, any urgency. Are you not incontinent, but are you not able to pee? And what else? Any blood in your urine? So yeah, you ask those type of questions, or any difficulty urinating. So any trauma, you can ask trauma. So yes. So, all right, focus physical. What kind of physical are you going to do? What are you going to look at? You're not going to look at every single thing. You're not going to look at his face, his neck, his chest, his belly, his back, his hands, right? You're going to do focus. So what do you want to look at? Did he injure his back? Great question. Any trauma? Great question. Yes. Abdomen? Yes. Good job. Abdomen, urinary. So urinary, of course, the only time for urinary, I wouldn't even say urinary, but for more like genitalia or your whatever. The only time I would look at the genitals, of course, for males, if it's like STD related, if they say they have a sore, or if they have like scrotal or testicular pain, that's the only time I would do that. Like, I don't do it if it's like flank pain, of course. And then, so yes, you're going to look at his lower back. You're going to touch his back. You're going to look for, when you do the back exam, you're going to look for any signs of injury or trauma. You're going to look for any redness, swelling, anything that looks out of the ordinary, how a back should not look like. You're going to touch his back. You're going to touch the, even though this is flank, you're going to still touch his muscles around his back, his spine, see if he has any spinal tenderness and paraspinal. Para means around, right? Para, spinal, para. You're still going to do a back exam because you got to, rule out different things, right? Paraspinal. Para means around. Spinal means your spine, right? So you're going to touch the actual spine, and then paraspinal around the spine, right? And then document all that. And you can do a straight leg exam, like raise their leg to see if they have any pain that can indicate disc stuff, like disc herniation. And then for back, even though this can be something else, you have to make sure you rule out the worst, right? Specific questions you'll be learned to ask for back stuff, like emergent causes of back pain is like a spinal epidural abscess, which is bad stuff. Cauda equina syndrome, you'll learn, which is bad stuff. It's, it can lead to why do I get these brain farts? It can lead to paralysis and loss of like bowel and bladder, or permanent loss of bowel and bladder. So you want to rule out stuff like that. You ask them, and this is for patients that have like that disc compression, that's compressing on the spine. So you asked about questions, even though this may not be it. Remember, we have to ask differential diagnosis. So you're going to ask about loss of bowel or bladder. You're going to ask about numbness / tingling. You're going to have to ask if they have any disc problem, like disc herniation, bulging disc, any trauma, like you guys said. This is for back stuff. Just anything, related to those body systems. You're going to do a back exam. You're going to do an abdominal exam. You already asked about urinary stuff. So let me see other back questions. I think that's it. Well, you're going to test. You can choose to test the reflexes. You can choose to test the reflexes. You can also test the reflexes, test the muscle strength and sensation and all that. I just keep saying I'm kind of forgetting because this is clearly you guys probably know this is not the diagnosis. But just telling you guys stuff to come to a differential. All right, so speaking of differential, your differential is a list of possible diseases / illnesses that could be causing your patient's symptoms. Check range of motion, right? Yeah, you can do all of that for a back exam. Makes the patient lean forward, lean back, abduction, adduction, rotation, all that. So the back musculoskeletal stuff is going to be in your differential, right? If you guys don't already know what a differential diagnosis is, it's a list of possible diseases / illnesses that could be causing your patient's symptoms, and it helps lead you to the goal of this is to come to a final diagnosis. So you're going to be doing lab tests and lab and imaging tests based on your differentials, right? Whatever you think could be going on. Your differential could be as long as you want it to be. Typically, it's 3 of the top 3 things, and then from that, you're going to come up with the final diagnosis. All right, so thinking about your differential, what are some differentials you guys have in mind? And differentials is going to come from your H&P, right? Based on the questions the patient answered yes and no to and their past medical history and all of that. So differential is not just based on the complaint. The differential is not just based on the chief complaint. Differential is based on the history, the physical, past medical history, past surgical history. If a patient comes in with abdominal pain and it's really bad and they're constipated or they haven't had a bowel movement and they have a lot of surgeries, the differential then is going to be a bowel obstruction because adhesions from surgeries can cause bowel obstruction. So the differential is not just based on the chief complaint. The differential is based on the chief complaint, the history, the physical, past medical history, past surgical history, family history, and social history, right? If it's an alcoholic coming in with abdominal pain, that differential is going to be different from a healthy person coming in with abdominal pain, right? So remember, medicine is you got to think about it in totality. All right, so let's see what you guys said. All right, disc herniation, UTI, pyelonephritis, gallstones, cholecystitis, kidney stones, muscle spasms. Yeah, I said check legs. Remember I said straight leg raise. Possible appendicitis. Good job, guys. Yeah, you can have back pain with appendicitis. Extremities, musculoskeletal. Great. These are some great differentials. Some differentials that I can think of is musculoskeletal. Of course, ruling out any spinal stuff like disc herniation. And of course, you have to rule out the worst, like a spinal epidural abscess or a cauda equina. But yes, and then a kidney stone, pyelonephritis, UTI that goes up to the kidneys. All right, great. What do you want to order with these differentials in mind? Liver issues, I wouldn't really think of liver issues. I mean, cholecystitis, is usually like that right upper quadrant pain. I've never really heard of back pain. Sometimes pancreatic issues can cause back pain, like belly pain radiating to the back or back pain. But all right, CMP, MRI of spine, intestine blockage, aortic dissection. Good job, Reba or Reba. Okay, so yeah, remember I said that. Good job. Aortic dissection or aortic aneurysm. So with an aortic dissection, that literally means that your aorta is tearing, like that's the largest artery and your whole body, and that's bad stuff because if it like ruptures or dissects, then you die. You're gonna basically like bleed out. So an aortic dissection is like one of the worst things that could possibly happen in the ER, aortic dissection or aortic aneurysm. So you'll have like a tearing back sensation, like it's like chest and back pain. It's with aortic dissection, it's usually upper back, right? And then as the aorta goes down and becomes abdominal aorta, then you'll feel like belly pain radiating to the back, like your thoracic or lumbar spine area or lumbar region. So that's a abdominal aorta. It's still the same aorta, it's just a region, right? So you always have to rule that out, like especially if they're older adults, right? Because they have years and years of damage to their arteries. So or they can form an aneurysm that blows up. So that's something that you have to think about. Good job. Remember I say differential worst first? That's one of the first things you got to rule out, especially with the blood pressure that high. Thankfully, that's not the diagnosis. But when you see a patient with a blood pressure that high, you have to ask them about family history of aneurysms, and back pain. If the blood pressure is really high and they have back pain and they're in their like 50s, 60s, 70s, 80s, whatever, this guy's a little young. But I mean, if you have like history of Marfan syndrome, where your intima, the lining of your aorta, the tissues are weak, like Marfan's or Ehlers-Danlos, those patients are at risk for aneurysms and dissections. So you have to ask about past medical history, family history of aneurysms, or does the patient have a history of Marfan syndrome or Ehlers-Danlos syndrome, or they have high blood pressure. So remember I said your history and physical and everything is going to yield the differential diagnosis. But great job, Reba. I wouldn't expect a pre-PA student to know that. Not that you guys are not smart, but that's just a crazy diagnosis. All right, so somebody said, what do you want to order? CMP, MRI of the spine? Excuse me. Okay, so you don't want to order an MRI of the spine because it's the ER, and MRI is a very lengthy test. Not that you never order an MRI in the ER. You can if you suspect compression syndrome, like if the cauda equina or spinal epidural abscess, like if the patient can't walk, if they're they're peeing on themselves, pooping on themselves, then those are signs to order it. If they their reflexes, they don't have any, or the sensation is gone, those are signs to order an MRI. But you wouldn't routinely order an MRI in the ER. EKG due to fast heart rate, back x-ray to check for trauma. Okay, we can do a back x-ray, but we're gonna do something else first. EKG, EKG is fine to do, but being that he's like a young, typically healthy male, like everything in the past medical history was negative, you guys, just for reference, and this guy's 42 years old, so I would do an EKG. I mean, the heart rate's not too fast, it's not bad to do an EKG, but you can. But it wouldn't be the first thing that I would do. CBC, spinal tap. No, I wouldn't do a spinal tap. I'll tell you why. UA, kidney function. You don't really rush to do like the craziest stuff first, like MRI, spinal tap. You have to have something that kind of you do before you do other stuff, right? Kidney function, ultrasound, CBC, CMP, ultrasound, CT. You guys have some great stuff you'd order. All right, so I'll show you guys what I would do. Okay, I would do CBC, CMP, lipase, UA. Did I say why? Oh, yeah, I did say why, but I'll tell you guys why after. Okay, so these are the tests that I would do, and I'll tell you guys why after, okay? All right, medication. So this guy's in crazy pain, right? His blood pressure is high. He's moving around when you're talking to him. He looks uncomfortable. You're going to document all that. So he's in crazy pain. So I would start with, fluids, with pain medicine, because my differential is also kidney stones. So fluids is really good for kidney stones to help the stones pass, and to help and pain medicine to help with pain control, and anything else you guys would order. So this is just kind of the way that I go about doing stuff. I'll order stuff and then do my documentation. So I'll order labs, meds, imaging if needed. Sometimes I won't order the imaging right away. Sometimes I'll order labs and medication first, and then go on to imaging based on like how the stuff is coming back, right? Oh yeah, for UA stuff, when you ask him urinary questions, he says he did notice some blood in his urine. He says that it's been burning a little bit when he pees. Let's say that. Pain medicine, yeah, you're gonna give him, yeah. So I said analgesia. So I put a question mark because I'm asking you guys, what would you give him? So he needs something for pain. What would you give? Tylenol. No, y'all. He needs something a little stronger than Tylenol, right? He has an IV in. Let's give him some first Dilaudid, a little less crazy than Dilaudid. So morphine is a really common and really, okay drug to give. It's not too strong like Dilaudid or too crazy or too like notorious. Toradol, I'm fine with giving him Toradol. So with Toradol, the only time I don't give Toradol is when they're older, because I want to make sure their kidney function's good, or if they can't take NSAIDs, or I'll ask them if they're okay with taking Toradol. Younger patients, I'll give Toradol too, if they don't have any kidney problems. But if they're older, like anybody over 50 or 60, I'll hold back on Toradol, and I'll just start with morphine at first. And then when their kidney function comes back and it's good, then I'll give Toradol. But as far as analgesia, like you can start with morphine, but Toradol is great. Oxygen or Percocet. When their patients have, you can give oxygen or I said oxygen. I see oxycodone or Percocet. My bad. Oxycodone. You can give some pills, but something IV is great, especially for our differential. I mean, musculoskeletal is in the differential, but this patient's in such bad pain. It's good to give something that'll like work like that, right? So I'll do IV meds and not like PO. So 2 milligrams of morphine is great to start with. And then I'll also give some Zofran. He said he was nauseous, and you can give Zofran a lot of times with morphine because morphine can make patients nauseous. All right, to image or not to image? To image or not to image? That is the question. All right, we have about 5 minutes left. To image? Yes, image. Great job, guys. Okay, so some people said X-ray, some people said CT. You'll see what I went with. All right, so I did a CT stone. The number one on my differential is a kidney stone. Why? Because the patient's presentation, the patient is like super irritable. He's like moving around. It's screaming kidney stone. When you see one kidney stone, you won't really forget how kidney stone patients look. They just look miserable. Not just that, but the way his complaint, the questions he answers, his urinary complaints that go with it, that's my number one chief complaint. And then when you do a CT stone, you'll also look at the spine too, so it'll catch the lumbar region, so that'll let you know if he had any type of trauma or injury to his spine. Doing a CT. And then a CT stone, it's called a CT stone because it's a CT without contrast. Because remember I said that contrast lights things up. So if you have a stone that's already light, contrast can mask that, right? So you won't be able to really effectively see a stone. Sometimes you can see a stone with contrast, depending on where the stone is. But you want to do it without contrast. So if there was trauma, you would definitely do imaging, but this isn't, there was no trauma, and this isn't pointing really musculoskeletal like an X-ray. This is pointing to more urology. All right, so what do you guys see on this? What do you see? And I wouldn't do an ultrasound. I only do ultrasounds if they're like pregnant, if it's a gallstone, you do a gallbladder ultrasound. If they're pregnant, you do a pelvic, or like female stuff, you do pelvic ultrasounds or GYN ultrasound. And then like fast exams, like ultrasounds for like trauma and stuff like that. The doctors does those sometimes, but like fast like trauma type stuff, but you don't really need to do an ultrasound. I mean, the patients that have hypertension and kidney issues and, stuff like that, they'll get an ultrasound done inpatient or outpatient. But good job, Zach. Yes, white spot is the ureter. So the white spot is actually the stone. Remember, the stone's going to light up. So you see where the kidneys are? These are the kidneys, right? And then right here is the ureter as you go down, as you're examining the CAT scan. So the white spot is the ureter. So what is the white spot? The kidney stone is in the right ureter. So when you're looking at a CT, it's going to be like this. So this hand is actually going to look at the right ureter. So this patient has a kidney stone in the left ureter. Okay, that's why he's in so much pain. So the ureter, okay, the kidney, I'll tell you guys about kidney stones, but the ureter measures about like 6 to 8 millimeters, right? Kidney stones can be bigger than that sometimes. So, and sometimes they're smaller than that, but they just hurt when you're passing them. Imagine like a rock or something kind of going through like a small tube. That's painful. So yes. All right, so this is why I ordered the stuff that I ordered. I forgot to include lipase, but I ordered lipase for a lot of abdominal type stuff, anything that's in the abdominal region. I don't order it for all back pains, okay? I don't order it for like if it's like a musculoskeletal back pain, of course. But if the patient has nausea, vomiting, if the patient, whatever, has a pain that radiates to the abdomen, then I'll order a lipase. Lipase is for pancreatitis. So yes, so CBC, because if you suspect a kidney stone, you want to make sure that the patient doesn't have a white count or a possible infected stone or UTI, right? And then the CMP, you want to look at the kidney function. You want to make sure that the kidney stone is not affecting kidney function. It's not causing an acute kidney injury or acute renal failure, and also messing up your electrolytes. And then you want to look, of course, for the urine for UTI, leukocytes. Remember, we talked about UTI like a few weeks ago, I think, and blood in the urine. When you have a kidney stone that's messing stuff up, causing a lot of pain, and causing issues with your organs, with your bladder, with your ureter, then it's going to cause blood to be in your urine, right? Would you order a magnesium? No, I usually he's been nauseous, not really vomiting, and I would order magnesium on like alcoholics and stuff. Sometimes abdominal pains, but yeah, I heard it was comparable to pregnancy. I heard that too. I mean, I've never been pregnant, but I feel like nothing's comparable to pregnancy. But it could be the next worst thing. So yeah, this is why I order these things, and this is why they're indicated. Okay. So let's say that everything came back. Okay, let's say that, of course, let's say he has a UTI. His white count is fine, though. His kidney function is preserved. His GFR and creatinine are good. Electrolytes are good, okay? Okay, so I'm sure you guys know about kidney stones. They're like these hard deposits that kind of form in urine as you're making urine. And they're very painful because they're like coming down your urinary tract. And even though they can cause some temporary damage. So if a kidney stone causes acute kidney injury, so it causes your GFR, the rate that you're making urine, to go down or increase creatinine, then it's just temporary, right? As soon as you fix the problem, which is the kidney stone, you're going to fix the GFR and your kidney function, right? So it's not going to cause any permanent damage as soon as you just fix the problem. And there's just risk factors for developing kidney stones, and we'll go over that. All right, so the main thing I tell patients is diet, because that's really what I've heard. Diet, if you have hypertension, you can be at risk of developing kidney stones. But high sodium, high protein diet, carbs, sometimes obesity, dehydration. So yeah, there's just certain risk factors if you have a family history of kidney stones. Like where I'm working now, I've been seeing so many kidney stones. It's probably like the main complaint or diagnosis that I've found since I've been at my travel job. Like it's so many, and I'm like thinking, is there something in the water or something? Like there's so much kidney stones going on there. So yeah, so what was I gonna say? Yeah, those are risk factors, and that's actually why I decided to do kidney stones today, because I've just been seeing so much of it. All right, but the good news is that kidney stones are relatively easy to treat. It's actually probably my favorite complaint, because it's easy to diagnose, easy to treat, but you just got to make sure you rule out other worse stuff. So fluids. I started this person on IV fluids right away because I was thinking kidney stones. So you just start them on a bag of fluids. You can add another bag or two of fluids, and they're gonna go home on fluids. And they're not gonna go home on fluids. They're gonna go home and be told to push fluids, drink lots of fluids. And then NSAIDs like Toradol, you can send them home with some Motrin. They're gonna get Toradol in the ER. And then you'll send them home with some Motrin that really, really helps with the pain, even when morphine doesn't. I've seen morphine not help, and then patients say Toradol helped. So NSAIDs, if it's not contraindicated, if they, don't have any GI bleed type of issues, if they don't have any contraindication to taking NSAIDs, if they're not on any blood thinners, or if they're not like super elderly and have bad kidneys already, or if they don't have one kidney, so they can get NSAIDs home. Narcotics, you can send them home with some Percocet or Tramadol or whatever for a few days. Flomax is a really good medication because it helps get that stone out, because it relaxes the smooth muscle in the ureter, and helps with expulsion of the stone. And then antibiotics, if they have a UTI, they don't always have to go home with antibiotics. I usually just do it if they have a UTI or if they have like a really high white count or whatever, because you want to make sure it's not an infected stone. And then a strainer. Not all hospitals have strainers. The strainer is to strain the urine, so you can catch that stone and bring it to the urologist and say, let's analyze this stone, see if it's like a struvite stone or whatever, what type of stone it is. Most of them are like calcium stones. So a strainer, like not all hospitals have them. It's not a must to have one. And then follow up with urologists. You want to definitely make sure that they leave with the urologist urology follow-up. You'll be able to add a urology specialist, whoever's on call, to follow up with that week or in a few days. And that's about it. That is typically outpatient management. The only time it's managed inpatient is when a patient has a large obstructing stone that's causing hydronephrosis or acute kidney injury. A lot of times they'll have an obstructing stone that is causing hydronephrosis, but their kidneys are preserved. At that point, I'll still call a urologist and I'll consult with them, and I'll say, okay, do you want this patient admitted, or are you okay with seeing the patient in the office? I'll just present the case of the patient, present the case to the urologist, and I'll tell the urologist what's going on and about the CT findings. And like if the stone is like 5 millimeters and up, I'll call a urologist. Or if it's causing like obstruction, or if the patient's just so uncomfortable even with meds, I'll call a urologist, and they'll like kind of make a decision. But if it's definitely causing an AKI is acute kidney injury, which means if it's messing up with the kidneys, definitely call a urologist, okay? You don't want to cause injuries to your organs. And then if the patient is sick or septic appearing, because it could be an infected stone, if they have a high white count, if they have a UTI, if they just look bad, you want to call urology. And if they're in just intractable pain, nothing is working, then you can call urology. They can do a lithotripsy or whatever procedure that they want to do. So these are the times that you generally admit a kidney stone. Of course, if you're not sure, consult with your supervising physician or consult with urology. So yes, that's about it. Is it due to the population people you see? Like a lot of the factors seem like they could come from a fast food diet. Yes, yeah, definitely. Yes, yeah, it could definitely. Like I said, a lot of times kidney stones is due to diet and the population. Like if it's more like a low income area or a underserved area, it can definitely be due to population. Because that just reminded me, I saw a lot of kidney stones in Middle Georgia too. Which population are more susceptible to be admitted with kidney stones, older or younger people? I would say, older people could be admitted, more susceptible to being admitted because, they're at risk of, damage to their kidneys more likely than younger people, right? Younger people heal quick, they get better quick, their bodies are better. I'm not gonna say bodies are better to, whatever, but yeah, their bodies kind of heal quicker, but it really just depends. It honestly depends. But that's about it. Any questions, guys? As always, know what's common, know zebras, know what can kill you. My contact information. Any questions, guys? I literally have to get on the road in 10 minutes. But any questions, guys? Thank you. Thank you so much, guys. Thank you. But if you have no questions, even if you do, feel free to message me. I probably won't be able to respond until sometime tomorrow. But do you consider admission at first glance or after recording labs? No, I never consider admission at first glance. I always wait for stuff to come back, and it's multifactorial. Thank you guys. I'm not sure if Bill Clinton was hospitalized due to that. Hope you guys enjoyed it. Thank you guys. Good night. Have a good night. I'll put my contact information again.